The logical step or the logical rationale behind this study is that we now have more and more data, including randomized phase 3 data from the primary investigator on this study, Dr. DiNardo, incorporating Venetoclax into treatment regimens using what we consider low intensity therapies for AML treatment, predominantly the hypomethylating agents, decitabine and azacitidine. And we see really robust responses and synergistic leukemic cell killing when we use Venetoclax combined with either of those agents. Similarly, there was the recently published phase 1b caveat trial where they used an attenuated schedule of the 5+2 regimen of idarubicin in combination with cytarabine, so cytotoxic chemotherapy, and added Venetoclax to that regimen in an older AML patient population. And similarly to the HMA therapy Ven combinations, we see improved outcomes in elderly patients with AML who traditionally have done quite poorly with intensive chemotherapy. And so then the next step is to say, can we further improve outcomes in a younger, fitter population with newly diagnosed AML, as well as patients with relapsed and refractory AML, by intensifying induction and consolidation with FLAG-IDA-based induction and consolidation chemotherapy combined with Venetoclax. So the methods used in this study were a standard 3x3 dose escalation cohort study for the phase 1b portion, the safety portion of the study, to determine both the maximal tolerated dose and identify any dose limiting toxicities, and the phase 2 portion where we assessed response and efficacy, were dose expansion cohorts in both the newly diagnosed AML patients as well as relapsed and refractory AML patients, with each arm enrolling up to 50 patients planned for each arm, and we're currently at 68 patients out of the 100 total expected enrolled patients. So the main finding from the phase 1b safety portion was not unanticipated, which is that when we add Venetoclax to intensive chemotherapy, we see that we have prolonged myelosuppression. So from a safety standpoint, we initially amended the protocol and reduced the dose of the cytarabine and the duration of the Venetoclax in the phase 1b portion of the study, because we saw an increased rate of myelosuppression and infectious complications. However, I think the takeaway, though, is that with dose optimization, we were able to safely combine FLAG-IDA induction and consolidation with Venetoclax, and we saw quite favorable outcomes, both in the newly diagnosed and the relapsed and refractory AML populations. In the newly diagnosed AML population, we saw a composite complete response rate of approximately 90%, including 96% of patients achieving measurable residual disease negative composite CR as assessed by multi-parameter flow cytometry. So this shows us that FLAG-IDA-Ven in the newly diagnosed AML population is able to achieve durable or deep, and the responses have been durable to date as well, but deep responses when we add Venetoclax to FLAG-IDA. Similarly, in the relapsed and refractory population, which continues to be a very adverse risk population that has poor outcomes and is in need of new therapies, we saw that we had a composite CR rate of about 67% in the relapsed and refractory cohort combined. And when we looked at the outcomes in these patients, what we saw is that 69% of these patients achieved an MRD negative composite CR. And so these were very, very promising results in the relapsed and refractory cohorts. I think, as far as survival outcomes are concerned, the newly diagnosed cohort has demonstrated very favorable overall survival to date, with a median event-free and overall survival that has not been reached at the time of data analysis. Although I will say in the newly diagnosed population, follow-up is maybe a little bit on the early side to have any firm definitive conclusions as far as the impact of this regimen on overall survival. The median study follow-up is 12 months. So I think the study follow-up is mature to discuss the survival impact in the relapsed and refractory population, AML population. And what we see in the relapsed and refractory population is that particularly those patients in the phase 2B cohort, which was the optimized Venetoclax dose in addition to the optimized cytarabine dose for induction and consolidation, we see a median event-free survival of approximately 11 months and a median overall survival that hasn't been reached. And the 1-year overall survival in these relapsed and refractory patients, so these are 23 patients in this cohort to date, was 68%, which is definitely an improvement compared to historical outcomes in this patient population. Grade 3 or 4 adverse events that occurred in 2 or more study participants were predominantly infectious and not necessarily unanticipated, particularly in myelosuppressed patient population and the relapsed refractory patients in particular. So the most common adverse events that we saw in 2 or more patients were febrile neutropenia, bacteremia, and pneumonia. And febrile neutropenia and pneumonia were fairly evenly distributed both between the newly diagnosed and the relapsed and refractory populations. We did see a higher incidence of bacteremia in the relapsed and refractory cohorts. This was driven predominantly by an increased number of patients in the phase 1B portion of the study developing bacteremia or sepsis prior to the protocol amendment and the dose adjustments of the cytarabine and venetoclax, like I spoke to previously. So I think the main clinical impact of this study is twofold. So I think in the newly diagnosed AML population, we do see that this is a very effective regimen that produces deep responses, particularly in adverse risk AML patients by ELN risk stratification. So this regimen could be used as an induction and consolidation in those intermediate patients that maybe between the patient and provider decide not to proceed to transplant. But I think really where it stands out is as a regimen that achieves deep remissions and is an effective bridge, appears to be an effective bridge, at least thus far, to transfer these patients to transplant. And the same is true in the relapsed and refractory population. Like I mentioned before, we're still looking for effective regimens in these patients. And I think to date, these are probably some of the best response rates we've seen in a prospective setting in the relapsed and refractory AML population. And this regimen is suggested that, based on our results so far, that FLAG-IDA-VEN could be a optimal regimen or an effective regimen nonetheless to bridge patients to transplant. I think probably the only other piece to add is that we are still learning that, it's AML treatment is not a one-size-fits-all approach. And we are exploring our biomarkers that determine whether or not a patient is going to be sensitive or responsive to FLAG-IDA-VEN and identify those patients that will be resistant. And that is something that, we'll have to continue looking at in our translational analyses. We see that unfortunately patients with P53 mutations, similar to prior studies, continue to have inferior outcomes compared to patients without P53 mutations, despite an induction intensification with FLAG-IDA-VEN. So this shows us that we still have a ways to go to optimize treatment, not just based on the clinical diagnosis of either, the frontline setting for newly diagnosed AML versus salvage therapy for relapsed and refractory disease, but really defining those molecular characteristics or the molecular phenotype, if you will, that will predict whether or not a patient will be responsive to this therapy. And then lastly, I just want to take a second to thank, the MD Anderson Leukemia Department, and then in particular, my mentor and PI, Dr. Courtney DiNardo, for allowing me to analyze and present this data at ASH. I think much of the credit goes to her and co-PI, Dr. Marina Konopleva, as well, for their work in this field.